Good evening. I'm Bruce Holmblatt. I'm the Riverside County Medical Association president, and we have our question and answer period with Dr. Cameron Kaiser. We've been doing this bi-weekly since the crisis has began. Once again, I just want to thank Dr. Kaiser for his leadership in this whole crisis. I know that he has made myself and my family feel safer. Why don't we just get going with Dr. Kaiser's update, and then we'll go on a question and answer period. And if there's extra time, some more questions have been put into the chat area, and Dolores will help with those. So without further ado, Dr. Kaiser, you've got the stage.
Thanks, Dr. Holmblatt. For those who are unaware of our current statistics, we have a cumulative total of 7,341 cases in Riverside County. 4,431 of those people have recovered. We have also recorded 313 deaths, and there are currently 199 individuals hospitalized with COVID-19. This does not include suspects, and 66 of them in the ICU. We're also continuing to monitor COVID-19 outbreaks which are occurring in our correctional system. Chuck Walla, for example, has had a recent outbreak. There are at least 102 cases recorded at that facility, which is of concern, of course, to Palo Verde out in Blythe. Some of those patients have been transferred out to desert facilities. In the county jails, we have 210 total cases, of which 134 have recovered. One of the orders which the Board of Supervisors allowed to persist was the school closure order through June 19th. This is of particular interest, of course, because the pediatric epidemiology of COVID-19 is very poorly understood. Particularly for our county, they represent a very small number of cases, and this seems to be true generally, but this is also maybe a factor of how many of them are tested. If you look at the positivity rates, and we have some preliminary data which we've broken down by school district, which I'll be discussing further with RCOE, their positivity rate is roughly about the same as everybody else. The real question then is whether they can transmit it as efficiently, and that is still a very open question. There's certainly the UK had pointed out that there's only been one reported outbreak associated with the school, but there was also a German study which seemed to indicate that they were perfectly capable of spreading viable virus. So we really don't have a good understanding of how that'll affect them. And certainly as the state has tried to come to grips with this and proposed guidance for the schools to open up, some of their proposals are quite startling and may have some logistical concerns, and hopefully whatever information we can get them will improve how they can inform that situation, figure out what they're going to do with it. There's also been some discussion about whether there are racial inequities in the number of deaths. Our epidemiology unit actually looked at this because one of the Board of Supervisors received a question about it. And the long and the short of it is in terms of deaths, African Americans are actually the highest group by rate, but only by slightly. The death rate per 100,000 for African Americans, whites and Latinos is 1.53, 1.33, and 1.08 per 10,000 respectively. So even though they are clearly the highest, it's also with very relatively small numbers, given that our total deaths are still in the 300s range. And we don't see the large disparity which has been popularly reported in the media and in some other jurisdictions. We've also looked at case fatality rate. Actually, the highest number there is American Indians and Alaskan Natives, but the number of cases is quite small. So that number could not be really used reliably. For African Americans, it's 7.73%, followed by whites with 5.97%, and then African Americans at 5.58%. And keep in mind, of course, that's case fatality rate. The actual infection fatality rate is almost certainly smaller because of the larger denominator, which is going relatively undiagnosed. Then again, and also looking at the percent of deaths in the population, again, African Americans are slightly overrepresented, but then so are whites. And these are relatively small differences, 7.52% versus 6.2%. of the population. Whites are 36.6% relative to 34.5% of the population. So, we want to make sure that people are getting the right figures. We want to also make sure that our testing infrastructure is reaching disadvantaged communities as well. This is a real issue for particularly our farm worker communities. But we also are not seeing the substantial minority disparities that have been seen in some other jurisdictions, at least not with the information we have in front of us. A non-COVID-19 point, and especially since regrettably I'm not going to be able to attend the board meeting on Monday because our state calls are usually around that time. But just as something to mention to people, no, there's other stuff on our plate as well. We do have a St. Louis encephalitis detection out in the desert. That's going to complicate our West Nile investigation slightly. But people should be aware, West Nile is of course still out there, and mosquitoes do not social distance very well. Just keep that in mind as moving forward. Zika fortunately turned out to be a bust, and we have very small numbers of it, and all of them are travel associated, but we do not have small numbers of West Nile. And as people remain home, and if they're not maintaining their pools or standing water on their property, I'm not sure what that would do to the rates, but it's probably not going to be good. So we need to make sure that we have that firmly in mind, especially since flu-like symptoms could look like really anything. With that concludes the majority of my report, Dr. Holmblad. So if you want to go to the questions, we can go from there.
Well, thank you very much, Dr. Kaiser, for that update. We'll go to the questions. Question number 1. How is the overflow of COVID-19 admissions from Imperial County going to affect Riverside County?
Right now, it is too early to tell. Most Imperial County patients have actually been going to a wide number of distributions. They've ended up as far away as Orange County, but the majority of them are actually going to San Diego. A minority of them are coming to us primarily of concern for the Southern County and the Eastern County right now. I queried our emergency management department to ask about how they're doing, and the numbers are currently within the amount that the hospitals in those regions can absorb. But people should keep in mind that El Centro Regional and then Brawley Pioneer, as of this writing, they are currently operating at or near capacity. They do have a federal medical station set up, and there is a CalMat team there, but it is possible at least some number of patients, and it's most likely to be the most ill ones, of course, will be transferred to Riverside County facilities on an ongoing basis. I'm sure you've heard in the news that the local outbreaks in northern Mexico have been quite substantial. Unfortunately, public health authorities there are overwhelmed, and we really have no good information on the epidemiology. We're only just seeing large numbers of cases being reported anecdotally. Also note that transfers are being largely handled through the state dispatch center. In a few cases, we've detected this was done as an interfacility transfer. The emergency management department would like to strongly discourage that. If you happen to be working on the inpatient acceptance side and you're taking these patients, please let them run through state dispatch. We actually had one very alarming situation where a documented positive individual who probably did not meet hospitalization criteria got transferred to an ED, actually got discharged from the ED, and then promptly got right on a bus. We are still trying to track down that situation, and we have yet to find the individual, although fortunately so far we haven't found anybody who's gotten sick linked to that exposure either. So please don't accept COVID-19 positive patients directly. Please have them please have the sending facility run that through EMS dispatch. They should know how to do that. Let them do the screening and routing. And then that way, if they're appropriate for hospitalization, then that way they're likely to go there and be monitored rather than a treat and street situation where we then have somebody who takes off into a public setting. We don't know where they're going. Of bigger concern, and unfortunately we have even less visibility into this, is of course the Mexican outbreak generally, because there has been some additional foot traffic to East County hospitals, particularly among the State Route 86 corridor. And facilities should be aware of the possibility, because it's very well known in Calexico, Mexicali, so on, that there is no room at Imperial County hospitals. So they're going to be going west and north, and some of them will end up on our doorstep. In terms of affecting our numbers, the state has assured us that these would not be counted as Riverside County residents because they're not. But then because if we happen to have somebody who actually is positive and is wandering around, or they become homeless or or housing unstable, that could be an issue as far as local outbreaks as well. So just be mindful of that possibility, particularly if you're out working in those areas.
Okay, thank you. Question number 2. What are the thoughts on the number of cases that continue to grow in the county versus deaths and hospitalizations, which seem to be somewhat stable?
I think this question got covered last time, but for the benefit of those who are not on the call, I'll go ahead and reiterate the answer. The hospitalization question, at least in part, seemed to be an artifact of people staying away from EDs and urgent cares. That is changing, however. If you look at our hospitalization information, that is starting to tick up again. As well as with COVID patients. So we are watching for that. It's not, I wouldn't consider it to be statistically significant right now, but it is going the wrong direction. So we're watching it. And I certainly would not characterize our deaths as particularly stable, certainly not within the last 14 days. I think the larger question, and the one I thought that this question implied, was whether the medical opinion on how dangerous the virus is changing based on the increasing case rate. I gave you some of the crude case fatality rates by ethnicity as part of my initial report. Overall, we're still looking at a crude case fatality rate of around 4.3% or so. Keeping in mind, of course, that even with asymptomatic testing, there are probably more undiagnosed living individuals than there are undiscovered deaths who are COVID-19 positive. So this number is without a doubt an upper bound, but it hasn't changed a great deal in the last few weeks. This is certainly a number that the state is going to pay attention to. Many of you may have seen that the county submitted an attestation to enable it to pass more quickly through stage 2. Part of our metrics on there is looking at positivity rate, and it's also looking at our epidemiology and our hospitalization numbers. So these are certainly concerning, and the state is watching. And if we see them getting to a point where we're crossing certain thresholds, I have no doubt that we're going to have to bring this up to the Board of Supervisors for further discussion. For right now, however, we're keeping an eye on the trends. The state has not waved the red flag at us yet, but I think it's definitely an indication that we all need to be cautious.
Okay, thank you. Question number 3. We do mostly plastic and cosmetic surgery in our surgery center. Can we reopen as long as we are taking proper precautions?
At least from the county perspective, I've never recommended any particular restrictions on what procedures or way the hospital may conduct business. The state has had some guidance that they recommended electives be postponed. At this point, given that the expected healthcare surge during the first wave is so far yet to appear, I don't think that there would be really any issue with doing plastic and cosmetic. You should still follow appropriate guidelines, and I think we're going to be repeating a question about that a little bit later. But as far as specific restrictions, if you go to covid19.ca.gov and also to the CDPH website, they have specific guidance for business sectors and then for healthcare facilities generally. But my understanding is that there is no specific recommendation and certainly not any orders. If you are able to open and you feel that that you can do so safely, then I don't see why you couldn't.
Okay, thank you. Question number 4. I am trying to reopen my office but cannot find PPE. Where do you recommend we get N95s?
Everybody has, all the selling off the back of the ship from Long Beach type people have shown up with PPE buys of shall we say, varying quality. The county itself has been doing several large PPE buys. We got burned on a couple, although fortunately we didn't lose any money in the transaction. But we are in a better position than we were previously, and I mentioned this on the previous call, but I'll also say it again here. Keep in mind that outpatient offices still remain lower priority than hospital and first responder requests, but we can fill some of them. Keep in mind, you may not and probably will not get everything that you ask for. And you are, of course, still expected to make every reasonable attempt to source and maintain a PPE supply chain yourself. I know that RCMA has attempted to do that for the membership as well. And the Emergency Management Department also reminds everyone that the mutual aid PPE system is just that. It is mutual aid. The expectation is that practices and institutions who participate and make requests should also be prepared to contribute into the system should we again have an issue with PPE stocks being impacted. If you understand this requirement and you would like to make a request, then the address that you can send it to, and I've sent this out before, but I'll mention it again, is MH as in medical health, MH resource, all one word, at rivco.org. That's RIVCO.org. MH resource at rivco.org. Make your request as detailed as possible. We have actually quite a lot of surgical masks in stock. I think we're doing pretty well in gowns. N95 still continue to be a problem for everyone. And again, we're going to prioritize acute care facilities, first responders, so on, particularly for those who are in situations like bronchoscopy suites and other places where aerosol generating procedures are occurring. But we still might be able to service outpatient facility requests. Just make sure you're very specific about it, and please be understanding if we're not able to fill everything that you ask for.
Okay, thank you. Question number 5, should all patients for elective surgery be required to have a recent negative COVID-19 test?
This was also addressed someone on the last call, but I will reiterate. The American College of Surgeons is not specific on this, but the general recommendation is that a negative PCR test prior to surgery is advisable, and we certainly have ample capacity at our county test centers if you are not able to do it yourself. In fact, we're trying to drum up business to make sure that we get the throughput which the state is watching for. So we are more than happy to see them if you are unable to do this test yourself. And those sites are all listed on our coronavirus page, which is rivcoph, rivcoph.org/coronavirus. And if you go right to the top, there is a big purple banner saying get tested for coronavirus, and you can just click on that. And that will list the locations, and you're welcome to send your patients over there. Please have them call first. A couple of the centers are walk-ups, but we really do appreciate people having appointments. We can usually do those appointments same day. Just have them call to make sure that it's open and that we can get them slotted in. That's rivcoph.org/coronavirus. Alternatively, you could also screen them plus or minus a mandatory quarantine period. And the ACS does list this as acceptable. But again, given the fact that we have pretty good test availability right now, as far as I'm concerned, it's simply just to test them. The bigger question that people are going to be dealing with is what to do if they're positive and how you clear them afterwards.
Right.
For the county, we are using modified non-test criteria, which is to say we're requiring them 10 days after the date of test. If they were never symptomatic and they never develop symptoms, then they can be cleared on day 10. If they do develop symptoms, then they need to be afebrile with substantial improvement in respiratory symptoms in the past 72 hours, assuming they're not taking acetaminophen or something that would mask their fever. You are certainly well within your rights to decide on the higher standard of 2 negative tests 24 hours apart. And we have enough capacity that retesting is allowable. But be advised, you will be waiting several weeks in some cases for clearance because they're going to be shedding, junk RNA probably for weeks. So just keep that in mind if you choose to insist on that higher standard. And in a high-risk setting, you may wish to do so. Neither the ACS nor the CDC really goes one way or the other. Just keep in mind you may be waiting a while.
Okay, thank you. Question number 6. Why has the county decided to lift the mask requirement? It doesn't seem safe for people to go without a mask, especially since there can be asymptomatic carriers. What advice do you have for clinics and other businesses?
Without going into the political discussion, the board chose to replace the orders with an official strong recommendation for facial coverings and social distancing. I'll just say personally that I wear a surgical mask when I'm seeing patients. I wear an N95, of course, for communicable patients. And in the TB clinic, whenever I have somebody in a negative pressure room who's smear positive, of course, I'll be wearing an N95 with them. And then I personally wear a face covering at all other times when I'm in stores or in the administrative offices or the EOC. There's sort of a middle of the road recommendation where people could use a surgical mask for asymptomatic individuals, since we, at least so far, even though there's evidence they can transmit it, they don't seem to be major drivers of disease. And then reserve your N95 stocks for symptomatic patients. A number of places have now adopted an N95 rotation schedule where you have one for every day of the week. keeping in mind that its survival within the N95 fiber matrix would probably be 72 hours at most. So by rotating it every week, you're well beyond that period, and then that way that can help to reduce the amount of stock that you have to go through. I will say that I think it is alarming that face coverings have become so polarized. I mean, anyone who's a student of history will recall that masks and, well, not really social distancing, but masks at least, and everything, you know, all the changes we've seen to the way society has functioned and changes of businesses, this was all part of the 1918 flu pandemic. And it, in fact, had some of the same backlash. ABC7 actually did a very nice story on it, if I do say so myself, since they used me as part of the segment. But they actually have some great historical pictures and images there which show that, you know what, if it weren't for the fact that, you know, everybody's walking around the 1910 fashions, this could have been last week. People who forget history are, as usual, doomed to repeat it. Certainly, the fabric coverings protect less well than surgical masks or N95s, and they do not replace social distancing. And when I've been working with the courthouses, I mean, one concern for the attorneys there is they would like to see people's faces, especially if they're doing voir dire or some other jury selection process. They want to get an idea of how the jury's reacting. If they're doing summations, they want to see how people find the statements that they're making. And to do that, they're going to need to be properly social distanced, and then they're going to use face coverings for other places to continue to reduce their risk. They add that extra layer to infection control, and everyone can make or get one very inexpensively. And I think exactly that concern over asymptomatic carriage, whether or not they turn out to be major drivers of infection, I think that should lead us to educate our patients and the public that, number one, it makes sense, and that, number two, characterizing it as a tool of oppression or some of the other statements I've seen is really unjustified. You know, I'll make a personal note here. My opposite number in Orange County, she's issued a similar order there. It brought actual protesters outside her home. Somebody read her personal address into a public board of supervisors meeting. And then they made a billboard with her face on it with a Hitler mustache in front of her kids, and then outside the county administration building. Now, I mean, I've personally heard Der Kaiser jokes since grade school, so I'm pretty used to cheap slurs like that. If you're going to be offensive, at least be original. But Dr. Quick is Jewish, so that's even worse. That kind of knee-jerk intimidation is inexcusable, especially for something where it really could make a difference. And regardless of the board's actions, they have, to their credit, made it a strong recommendation. They do continue to endorse it. And I think that we should really have the leadership here to point out, yes, it is not a complete solution to the problem. No, not everything is perfect, but it can be part of the solution, and it can give us, you know, that extra edge that we need. You know, everybody's still talking about whether there's going to be a second wave or not. And, you know, Tony Fauci has certainly walked that line back and forth a couple times. But the long and short of it is, if we're not careful, then we're going to get one for sure.
All right, thank you. Question number 7, is Riverside County doing rigorous contact tracing on all new positives? If no, why not? And if yes, why aren't you sharing the information with the public? I think you're sharing the information with the public. You've done very good here. Yeah,
we hit this one previously too, but for those who weren't on the call, the answer is yes, and we are actually required to do so. That is part of our state metrics. We are required to have, I believe, 380 contact tracers. We're trying to get them online as soon as possible. We're doing this through a combination of county workers who are being redirected from other departments, those who are doing telework. They'll be put into that pool. We're trying to contract out because HR's wheels turn slowly in any bureaucracy you work in. So we're getting some contractors online, trying to get that number up so that we do so. It's, you know, I think that anybody who's worked with us on something like a TB exposure can attest. We have a very conservative definition of who counts as a contact, and people will be contacted. And I think it's also important to keep in mind that contact tracing, I mean, I'm sure most of the people on the call know this, but to hear it in the media, you'd think this was some new innovation in public health, but this is really bread and butter. I mean, we're doing contact tracing for TB, we do contact tracing for STDs, any communicable disease. Contact tracing is the bread and butter of making sure you don't get more. And it's really taking an unjustified black eye because it's getting mischaracterized as some intrinsic invasion of privacy. Frankly, we intend to conduct contact tracing for COVID-19 in the same way we would for any other communicable disease, with the utmost concern for safety, comprehensiveness, and safeguarding the privacy of those we interact with. This is not something new to us. It is not some new thing we've added to our playbook. We're going to be doing it the same way we've done for other kinds of communicable disease exposures. And those who have been in contact may rest assured that we will make sure we reach out to you and get you taken care of.
Thank you. Question 8, has Riverside County received any remdesivir doses? If so, what is the process to determine who receives any allotment?
We have actually received about 1,500 doses of remdesivir from the HHS so far. This is being distributed through the Medical Health Operational Area Coordination System, the same one that's handling MASS. I'm involved in that, and so is Dr. Vazizi, the EMS medical director. The constraints we've been working with is we want to make sure that we keep as close to a 6-dose course as possible. The 5-day course has a 2-dose loading. Similar, there's also a 10-day course with what's an 11-dose. We're trying to keep it to 6 to make it simpler. We're doing this proportional to hospital confirmed caseload. We are weighting ICU cases more, right? In the current model, we're doing it, an ICU case counts for 2 on med surge because we imagine those people would be higher priority for receiving it. Although there's some evidence to suggest that the earlier you do it, much as with Tamiflu or oseltamivir would benefit. So the recommendations shift, but right now we're trying to bias us towards critically ill ones. And we're also trying to make sure that every hospital, even the small ones, has at least some in stock. For example, as I mentioned, we have that outbreak going on at Chuckwalla. Some of those patients will end up at Palo Verde. Some of them may not be able to be transferred expeditiously. It may be nice to at least get them loaded on remdesivir, and they'll have a stock there which they can do so. We dispersed the first 905 doses already. Your facilities already have them. Everybody got some in that first shipment. We have another 550 odd dose shipment, which will go out this week. Hospitals are responsible for their own procedures regarding patient selection. There was some talk about trying to come up with a unified county standard, but I think with the number of acute care hospitals we've got, that is going to be very difficult to get everybody to agree on it. We are, however, sending out the state and national guidance, so at least you have something to work with. I do not know how long the shipments will last. And also, I have seen some recent studies that suggest that remdesivir may not be as big a game changer as it's been hyped to be. I don't think it's going to go the way of Plaquenil, but still. Nevertheless, as we receive it, we are getting it out to hospitals as quickly as we can. We're trying to make it as fair a process as possible. I personally would be very interested for those facilities who've gotten them. Won't be a surprise that given the numbers, RCH has been getting quite a lot. So is the RUHS Medical Center, Eisenhower Desert Regional. These have all been receiving a fair bit of it because of their burden. If you happen to be working inpatient at one of those facilities, I would be very interested in your impressions. And I'm sure your facilities would like to know that as well, just to get some anecdotes out of the community about how valuable it happens to be.
Okay, thank you. Question number 9, will there be relief fund coming from CARES Act for the pediatricians, medical providers, and others that do not see Medicare patients?
The county got $431 million in the first CARES Act allotment, and I think we're going to get something like another $57 million more. The primary purpose of that is reimbursement, and $100 million of it is going to do things like reimburse the March Air Reserve response, which was quite costly for the county, and obviously our current expenses, which we are sustaining. However, $50 million will also go into a business aid fund, which is yet to be further elucidated. The Board of Supervisors has already passed a motion directing that. County EDA is now determining eligibility and process. I would imagine that physician practices that do not take Medicare could apply for that money, but I don't know how they're going to bias them to that. Stay tuned. I can't guarantee whether anything will be available, but I can certainly, the Economic Recovery Task Force may be your first point of contact. If you go to the coronavirus site, there's a linkage there for business resources, and if you wanted to keep abreast of that. You will note that that only covers 150 million of the 431 and then the 488. the reason is simply because the county is still figuring out what to do with that. We are probably going to move that into a specific account to handle things such as response preparation. There's a specific allocation there for congregate care facilities, or particularly the vulnerable populations that are addressed, especially given that again is also a state metric. Sheltering resources, the county is a member of Operation Room Key. Homelessness, things like that are also being addressed from that money, and regional hospital response. And of course, we have to figure out some way to spend this all by December. Now, we are local government, so we can figure out how to spend a lot of money in a short period of time. But nevertheless, at least of the $50 million in there, and possibly additional to come, there may be some option for those physician practices. I just can't guarantee it right now. The information is only very preliminary.
Okay, thank you very much for answering the questions. I don't know if you have a little bit of time there were some other questions put on the chat. Dolores has, if you can answer a few more, that would be great, but we want to be respectful of your time here.
I've got a few minutes.
Dolores?
Okay, so there's three questions. How has or is the May revision going to affect public health in Riverside County?
Probably not well. Our bigger concern is, of course, as you've heard, the county will be doing somewhere between a 5 and 10% haircut. Unfortunately, we are one of those departments. We're probably looking at about $1 million out of our net county cost. That's a big cut to absorb. Everybody is being asked to do so. We will see what happens during budget hearings, but we expect that the state news will similarly not be positive, and that's why we're really relying on a lot of the CARES Act funding. Again, this is a problem for ongoing positions because the money disappears in December. Whatever we don't spend, the feds take back. So we can't really use this to fund ongoing positions, which is really what we need. But nevertheless, I think it's fair to characterize that the news would not be good even under the circumstances.
Okay. The next question, is there a standard protocol for offices opening to patients to follow during the COVID pandemic?
CDPH actually has a page on this. If you go to their COVID-19 one, I apologize, I don't have the link in front of me. I can try and dig it up. They do have a standard guidances for outpatient facilities. And that addresses many of the questions that people have about proper office practices and recommendations and so on. There was also a question, I think it was either last night or last week or last time or the time before, where they asked about for people who are primarily working in an office setting. If you go to covid19.ca.gov, they have a list of business sector ones, and there is ones for office work there as well, which may be more relevant to a back office environment. But for the front office, the CDPH site would probably be the best one to get that information.
Great, thank you. And the last question, can you clarify again the efficacy of N95 in terms of time?
I'm not sure how to answer that question.
How long is an N95 good for?
Okay, all right.
I think that's what Dolores is trying to ask.
I'll assume that's what Dr. Raj was looking for. The guidance that they've given about rotating the mask is really, predicated on how well COVID-19 survives within the matrix of the mask itself. Since we believe that its maximum lifespan in the environment is 72 hours tops, and probably much less, then it is unlikely to survive within a mask for anything approaching that period as well. As far as the mask efficacy and how much you can reuse it, actually it seems like the rate limiting issue for masks is the elastic. That is usually the part of it that goes bad first. When an N95 expires, that's usually because the rubber or the stretch filaments within the elastic bands have gone, and then that means you will not have as good a face seal. If you're dealing with masks which are up or near their expiration period, that could be an issue. But as long as the mask is otherwise physically intact and using it specifically for those, then you might be able to get away with it. Now, of course, we're using N95s in other settings as well. Like I probably wouldn't do that for my TB patients because I'm not really sure how long an AFB positive bacterium would survive within the matrix of that mask either, and I don't really want to find out. But for those of you seeing that and you're concerned about COVID-19, if that were your biggest risk, you could certainly do it that way. Just be mindful again that all that, the stretching and reformulating, of course, takes a toll on the mask's physical integrity. And if there is any concern about it or it becomes soiled or perforated, then it should obviously be disposed of.
Okay. Well, Dr. Kaiser, on behalf of the Riverside County Medical Association, we once again appreciate your time, your effort, your leadership, and taking time to answer our colleagues' questions, as you do very well all the time. So on behalf, once again, I want to thank you very much.
My pleasure. Thanks for having me as always. And Dolores, Dr. Leung should be following up with you about Monday.
Oh, that's great. Okay. And just, there was one question asked and it was regarding the websites that Dr. Kaiser mentioned, and we have all of those posted on our COVID website. And so if you go to www.rcma-docs.org/COVID-19, you can find all of those links there that he mentioned.